Good morning, ladies and gentlemen. Thank you very much, Professor. Thank you for this very honorable privilege. Today, I'm going to tell you a story about testosterone, a journey of a testosterone. So I call it releasing the inner beast of metabolic syndrome. Okay, before I begin, I would like to share with you a story, okay? I just want to tell you a little bit about my background. I started my career as a pharmacologist. I went to Cambridge and did pharmacology. After pharmacology, I did surgery in Oxford. And then following that, I was in London, and Imperial College London, for urology training. So after 21 years in UK, you get really, really drained. And then this is a picture that my son took for me. This is a Senate House in Cambridge where we graduated from. And then my son said to me, "Dad, I want to take a picture of your poster picture." There was a scaffolding company there, say erection specialist. My son said, "It's very funny that you are the erection specialist." And then my student there said, "Nice shot, Prof." And even the bin truck at the back there said, "George, the erection specialist." So I think that was quite funny. The interesting thing about this is I'm not so concerned about this erection specialist. But when I looked at my picture, this time I was leaving UK, I was 36, I felt old. I looked at this man, I just said, this is what aging, or this is what 21 years of United Kingdom does to you, right? I felt old. So that was a year, 2007, I decided to go back to Malaysia, and which is home after spending 21 years in Malaysia, which is home. And this is what happened to me. So when I got back to Malaysia in 2011, I became a 108 kilo man. So suddenly I realized that life is too good in Asia. You eat well, you sleep well, you travel well, you drink well. And this is what happened to you when you turn into a metabolic syndrome. Suddenly, you know the plumbers who does your plumbing, they have something called the cleavage at their back. Suddenly, I had my cleavage, and this was me. I had diabetes, I had obesity, I had hypertension, I had dyslipidemia. And that was when I one day looked at that picture and realized that from an aging man, I turned into a metabolic syndrome man, and I have to do something about it. And that is when I look very closely into what exactly is metabolic syndrome, what exactly is testosterone, and do I have andropause, and how do I overcome that? So let's deal with exactly what metabolic syndrome is. In a simple form, metabolic syndrome is 4 entities. You look at truncal obesity, you look at hypertension, you look at the glucose intolerance and dyslipidemia. And that is a simple form of metabolic syndrome. And many societies come up with consensus. They will say, the waist circumference. At that time, my waist was 38, so yeah, I qualified. Elevated TG, reduced HDL, yes, again, my dyslipidemia was all over the place. My blood pressure was 180/90. My fasting glucose and HbA1c was 6.9%. So under any criteria, I fall under the realm of metabolic syndrome. Then I started asking myself, how common is metabolic syndrome? We all talk about metabolic syndrome being common in the United States, but it's not really that common in Asia, is it? And that's when I find out that actually it is quite common worldwide, and it's increasing. So if you look at a 20 to 39-year-old man, it's about 15%, and then it's increasing to about 16%, but 60-year-old man, it can be around 50%, but it is common, and it's common with increasing age as well. So this is something that is not just an American dream disease. This is something of everybody will be facing it, and we need to do something about it. At the same time, when I was having problem with my weight, my hypertension, my dyslipidemia, I also begin to feel tired, and I begin to feel like maybe sexually I am not as driven as I used to be. And I start thinking about, is it something to do with my testosterone? Because as we get older, our age decrease, our testosterone decrease. As we get older, our metabolic rate decrease. And this is something that I started looking into. Men with metabolic syndrome have lower testosterone. On the other hand, low testosterone will induce metabolic syndrome. So it's like chicken and egg. Which started first? We don't know. And today we're going to go through the journey to find out which started first. It doesn't matter, but what we need to do is break that vicious cycle, okay? So although the relationship is unclear, but we can stipulate a few things. Number one is that the testosterone level generally with age will come down. The free testosterone will come down, the total testosterone will come down. And the sex hormone binding globulin will also go up, making sure that your free testosterone is depleted. At the same time, the prevalence of metabolic syndrome when you're younger, at the age of 20 to 39, is only in the region of about 20%. But it will shoot up to double that at the age of 40 and 60. And that is a problem that we link testosterone with metabolic syndrome. So what started first? Some people argue the low testosterone itself actually causes a muscle wasting and then induces fat accumulation. And that itself will cause visceral obesity. Some people argue that it's because we don't exercise, we eat a lot of carbohydrate, and that extra reserve of visceral fat causes insulin resistance and increase the aromatase estradiol inflammatory process and causes the testosterone to drop. I have a theory, and this is what I think happened to me. I think as I was getting older, my hypothalamus and pituitary dropped my GnRH release, and my Leydig cell perhaps is decreased. As a result of that, I am testosterone deficient. As a result of that, whatever I put in my mouth, the consumptions without exercise will cause visceral obesity, and that itself resulted in metabolic syndrome and inflammatory changes. But what I was more worried about was the end product of this, the clinical relevance of it. Eventually, this is also equivalent to endothelial dysfunction and eventually might lead to my death of cardiovascular disease, stroke, and also other issues. So as a result of that, I begin to look very closely. What is the link between metabolic syndrome and the testosterone? You can see that if your testosterone level in the higher percentile, your risk of relative risk is significantly lower as compared to the lower percentile, which is significantly higher. So if that low testosterone is a prediction of your metabolic syndrome, is there any study to show that? In fact, there are multiple studies. Meta-analysis of a lot of longitudinal studies shows that the mean testosterone difference of 2.17 nanomole per liter actually increase your risk of metabolic syndrome, and subsequently that will lead to an early warning sign of cardiovascular disease and diabetes. So on that basis, I begin to link testosterone and my metabolic syndrome, and I begin to really look into, is there a need for testosterone replacement? And that is when I really want to dwell back to the medical school time of what exactly is testosterone and how is that going to influence me if I use an exogenous testosterone. Let's go back to medical school, right? Testosterone is the major androgen in a man's hormone. So it is constituting 95% synthesis from your Leydig cell in your testicles, and the rest of it's from your adrenal glands. It's secreted in the bloodstream. It is crucial for the male sexual differentiations. It's crucial for puberty, and subsequently maintaining a secondary male sexual characteristics. So in some way, it's our determination of our identity as a man. However, testosterone also has many other roles. Like I mentioned to you, this physiology of hypothalamus pituitary axis. We started off hypothalamus that produces GnRH, then pituitary glands, and then it will activate the testicles and produces testosterone. Apart from that sexual differentiations in puberty and also in childbirth, we also know that testosterone itself is important for protein building and metabolic activities. And that perhaps is the part that is causing metabolic syndrome. So the testosterone itself has a widespread influence on a man's body. Sometimes we call it the fountain of youth. Why? It's because in the brain itself, it creates your mood of that drive. In the skin, it gives you very tighter skin, less wrinkles, and more secretions and more moist. On the muscles, it makes you look stronger, it makes you look muscular. In the liver, it produces more proteins. In the kidney, it actually makes your erythropoietin higher and makes you more tolerant to exercise. In your joints, it actually modulates the immune response, make your joints stronger. In bone, we all know testosterone is crucial in order to maintain bone strength, and also male sexual characteristics such as penis, testicle, and prostate growth. So we know testosterone's impact is widespread, and therefore, in some way, testosterone itself is a fountain of youth. But the testosterone is not just the story, because it's complex. The testosterone itself comes in various forms. 45% of testosterone itself is bound to sex hormone binding globulin. Another 50% is bound to albumin, and the true active form of testosterone, it's only a 4% free testosterone. So therefore, by measuring the testosterone itself is not adequate way of finding out how the testosterone is influencing you. Apart from testosterone itself, we also don't really look into the testosterone and estradiol ratio, because that ratio itself is also crucial in determining a lot of sexual functions and metabolic activities in a man and also woman. So we always simplify it, and I want to show you a lot of complications that when we oversimplify this. The other issues about testosterone is that to capture the testosterone level is difficult, because on a daily basis, our brain will influence the productions by circadian cycle. Early part of morning, between 8 to 12 o'clock is when we measure the testosterone. It's at its peak. But it will drop throughout the midday and rise again, and on a daily basis, that circadian cycle occurs. So therefore, capturing testosterone only on a snapshot of one time, it's not the ideal way. Apart from that, our testosterone itself will naturally decrease. When we reach the age of 20 to 30, it reaches its plateau and then slowly get down beyond the age of 60. So therefore, testosterone at different ages plays different role in different men. So the big question is, how low is a low T? So therefore, today we start exploring different society has different threshold about testosterone deficiency or andropause. So let's start with the definition first, right? Androgen deficiency is a condition related to not enough exposure to androgens for normal functions. If you just look at the symptoms, you perhaps see 1 in 200 men below age of 60 may have symptoms of andropause. But as we age, above 65, then it's about 10%, about 70, that can go up to about 20%. And that is generally the level that we see in the prevalence of symptoms. But the causes itself actually is a lot more complicated. To start off with, the primary reductions of testosterone because of testicular failure is not common, because these are conditions such as testicular tumor, congenital acquired orchitis, or Klinefelter. That is a primary testosterone deficiency. There's a secondary one which is caused by the brain. For example, hypothalamus and pituitary causes, Kalman syndrome or chronic illnesses, sleep apnea might reduce the GnRH production, and also pituitary causes such as pituitary tumor or surgery might be causing that. But in clinical practice, we don't see too many of primary and secondary. But in the form of testosterone deficiency, perhaps what you're seeing is aging, which is a dual hypothalamus axis defect, which is a mixed defect. And that itself, in mixture with metabolic syndrome, perhaps is the cause of testosterone deficiency. And the andropause itself will have this spectrum of symptoms. To start off with, the general effect is that the body hair losing, height loss, and also the low trauma fractures, low bone density, and that's generalized. Effects on sexual, incomplete sexual development, reduced sexual desire, decreased spontaneous erection, all these are the sexual implication of low testosterone. In the psychological form, somebody will be less motivated, a bit more moody, a bit more aggressive, loss of self-confidence, and feeling sad, and that itself is the mood impact. But generalized, it might cause anemia and also decreased physical and work performance. So the impact of low testosterone is generally widespread. And therefore, in order to identify one specific symptoms that would define what andropause is, it's almost impossible. So a few society will start looking into what exactly should we use as a cutoff for definition of low testosterone. And I can find you 4 very important epidemiological studies. First of all, we have the Baltimore longitudinal study of aging, where Massachusetts male aging study, hypogonadism in men, the HIM study, and Boston area community health study. Remember, all these are American studies. Most of them are in affluent East Coast American cities, defining what the metabolic syndrome is. And they came up with these thresholds. For example, the Boston study actually defined what low testosterone should be is 325 nanogram per delta liters, and they came out with prevalence studies of 12% at 50 and 50% around the age of 80. Then the Massachusetts studies actually came up with different ones, which is a baseline of about 6 to 12%, and then similarly, with total of 300 nanogram, it's about 40% in HIM study, and then also in Boston studies, it's about 18%. So you can see that even amongst the experts, we cannot define what is low, and with such array of all these different thresholds, it always makes things complicated for us. In order to define it even worse, that when you start looking into the definitions from guidelines, this is the guidelines for International Society of Andrology and also International Society of Aging Male Studies. You can see that the biochemical syndrome, when it is defined as syndrome, is actually quite easily defined. But when you start looking into the levels, different society has different levels. For example, in a lot of Europeans, threshold 8 is the number that is used in order to define what is the low level that needs substitution. And there is a gray area, which is between 8 to 12. In the American Endocrinological Society, the definition is around 10, and then also the other recommendations in the guidelines is also different. To add another complication to all these is that the measurement of testosterone, it's very varied. Some people use saliva, some people use different assay, and this is one study to show that in the US Endocrine Society, they see that there's 891 labs have so many different assays and they have different ranges. So therefore, can we translate all these to Asian study? The answer is not necessarily right. But my recommendation to you is don't get too hung up about the actual threshold. So think of testosterone deficiency as a spectrum. So anything that is in the region of about 12, patient will start losing libido and also their vigor. Anything between 8 to 12, patient will start developing metabolic syndrome. Anything below 8, these symptoms will become critical and might have significant impact on their heart, and also the metabolic syndrome itself might lead to cardiovascular diseases. When you think of it that way, it is a lot more applicable to Asian society, and also it is less confusing when you start using guidelines from different societies. So therefore, ladies and gentlemen, what we now worked out is that perhaps there is a gray area, but what we know is that we need to define the people who are normal, who perhaps don't need treatment, and the people who are in gray area and low area might need treatment. And that's when we start going into the superhero is going to help us. So this is the metabolic syndrome Batman. That's eventually just need that androgen injected into them or applied to them. So let's look into the history. From very beginning, we already know that testosterone itself is the replacement that might give men fountain of youth. In fact, in Chinese culture, all the lotions and potions is working on one thing. The yin and yang is always to push up testosterone. About 100 years ago, even the Western medicine is trying to apply testicles of monkeys in order to inject into men to see whether we can raise the testosterone. But it's not till the 1940s, after the war, that we begin to use the pellets. From there, it developed to injections, oral treatment, patches, gels, and also the injections by 2004. So it's a journey of about 80 years old. It's nearly 100 years old. It's nearly as old as this university. And that journey is still continuing to find out what is suitable for what patient. So our aim is very simple. We try to make the testosterone as close to normal as possible for the age appropriate. We try to alleviate all the symptoms. We make sure that it's safe, and we make sure it's friendly. And that is the aim that you need to think about when you replace testosterone for your patients. So by replacing it, you need to constantly monitor the mood. You need to make sure that the erections and also libido matches the patient's expectation, measure bone masses, muscular strength, and the aim also is to reduce bodily fat. So with that in mind, we also have to think of the risk. We know the definite risk of testosterone replacement might be erythrocytosis, might cause polycythemia. We worry about some men complaining about acne, detection of prostate cancer, metastatic prostate cancer, and also sperm count reduction. These are proven correlations of risk of testosterone with elderly men or aging men. But other weaker evidence that sometimes application of testosterone might cause gynecomastia, we might warn patients about male pattern baldness, worsening BPH symptoms, potentially breast cancer in BRCA genes patients, and also worsening of sleep apnea. So looking into those, then you start thinking about what are the ways to monitor your patient. Obviously, as a baseline, started measuring the symptoms, measuring total testosterone, doing the digital rectal examination, PSA, hemoglobin, and bone density. And a few of the organizations, such as EAU, will start recommending 3 months to 6 months, 1 year, and 2 years monitoring to keep it safe for your patients. I'm going to use androgel as a form of replacement, and I'm going to show you the journey of what an androgel patient will go through. So the androgel trials actually started with a 6-month trial with 180 days of applications. If a randomized double-blind androgel versus placebo group over 90 days, and it's come in the form of T-gel and T-patches. The study also extended to 3 years follow-up and look at the patients for the impact and also the actual side effects. And this is what you can expect from your patients after 6 months. First of all, the pharmacokinetic, despite this being gel, is sustained. It's robust that after T level is restored and will generally maintain within normal range, and by 30 days, 60 days, and 180 days, the level is sustained. So it, although come in the form of a gel, it is actually as equivalent to the form of injection. So as far as the level is concerned, you can be assured that your patient is receiving enough. Subsequent to that, what about sexual activity? You can see sexual motivation, performance, desire, and satisfaction initially was low, it will go up, and after 180 days, it will also sustain. As far as the performance is concerned, again, to start slow, it will go up as well. The mood for men will also sustain. So the positive mood is sustained after about 30-day period, and the negative mood will reduce. And the body composite from the actual increase in body lean mass and also decrease in the fat mass is quite pronounced. You can see that the total body mass will sustain and the fat will decrease by the 180 days. So when you look at that, there are also studies to show that the bone density by 180 days, after the initial application measuring the hip and the spine, you can see that the bone density will gradually go up, and then that itself obviously is important to prevent the osteoporosis and fracture. So we see the benefits now. What is the drawback? So this is a safety result from 3 years. The adversities was reported to be 3% and 5%. Some patients has enlarged prostate and BPH, and some patients has elevated PSA. But at 3 months, there is no prostate cancer detected. Other issues that we see is that we begin to see abnormal blood result. So it's crucially important for you to detect your patient's hemoglobin. The actual lipid will get deranged because the HDL ironically will come down, the TG will go up. Some patients might have hypokalemia, some patients' glucose level might go up, but the creatinine might go up due to the muscle bulk rather than actual renal impairment. So this is what you can expect in about 3 months after the initial treatment. After 3 years of the treatment, you can see that the muscle strength sustained, compliance might drop a little bit, the PSA has no significant increase, the tolerance on skin irritation remains roughly the same. Let's look at adversity after 3 years. This is what we begin to see. About 11% of your patient might have enlarged prostate. There were 1.2% of prostate cancer detected, and some of the men, who are especially older men, will begin to get lower urinary tract symptoms related to BPH. So these problems of nocturia, urinary hesitancy, and incontinence begin to kick in. And the blood chemistry will continue to be affected, such as polycythemia, liver function tests, and cholesterol and creatinine. So that shows that the testosterone replacement, it's not the holy grail, but it is one of the ways to get your patient out of the metabolic syndrome. But the most bulk of the work has to come from your patient's motivation to exercise, to sleep better, to have themselves hydrated, reduce stress, and also cut down on fatty food and carbohydrate. So I'm sure a lot of you will ask the big question, what about the big elephant in the room, the JAMA paper? The JAMA paper was published, actually highlighted that association of testosterone therapy associated with mortality and myocardial infarction, increased risk of fatal myocardial infarctions. And that paper led to the media pickup by New York Times in about 9 years ago. And New York Times came up with a few statements. Testosterone doubled the risk of cardiovascular disease in 7,000 men. Compelling evidence that American men are embarking on a perilous course of overtreatment and testosterone being prescribed to men who are simply reluctant to accept that they are getting older. Is it fair? Let's dwell into the paper itself. The paper actually looked at about 8,000 men who underwent arteriography. And out of these men, they look at the men who have low testosterone and they look at the endpoint of mortality. The men who did not receive testosterone were eliminated from the study. The men who received testosterone, which is only about 1,200, were noted to have myocardial infarction risk of about 10%. So in reality, this is not a fair study because you eliminated a large proportion of men who in this study and specifically look at men who receive testosterone. But in reality, the risk of myocardial infarction is only 5.8% when you exclude men who, when you include men who did not receive the testosterone. So in conclusion, I think the JAMA paper is important. Although that itself doesn't show that data cannot be applied to general population because it is not general population what we looked at. Out of 1,000 odd patients who received that, it is very specific type of patient. That abstract subsequently was retracted because it was felt that it was misleading. But subsequent to that, there were a few other trials. New England Journal of Medicine come up with T trial to show that actually out of 790 symptomatic men, a lot of them will have no difference in major adverse event when they receive T and placebo. And further meta-analysis out of 75 placebo-controlled study, to date, the largest data found that there's no evidence of risk and it's clear evidence of improving metabolic profile. And that is the forest graph that actually shows that it's more benefit rather than risk. So at the end of the day, replacing testosterone itself, it's not an easy task because it carries risk. At the moment, there's no large trials. There are numerous observation studies, modest number of smaller studies that show there's no cardiovascular problems. And then lastly, clearly, like any other robust evidence-based medicine, we eventually need a larger trial in a prospective manner. So in conclusion, ladies and gentlemen, I think in the world of moderation is clearly important. When we get a confronting forces of testosterone overdrive, Kim Jong-un and Donald Trump clearly is a sign of testosterone overdrive and destruction will happen. And when we use it in moderations with an encouragement of patients in order to take over itself, of healthier lifestyle, then life will be a lot better. So I'm going to conclude and get some questions from you. So I'm going to show you a final picture. This is the picture before I embark on a healthier lifestyle, which is a radio show that I do in Malaysia. And that was a 108 kilo man. Today, this morning, when I weigh myself, I was 75 kilos. So I am really, really pleased. And I think that doesn't come with a lot, that obviously come with a lot of hard work as well. I can tell you, testosterone is not just the answer, but it might just be one of the solutions. And this is what eventually life will look like if you embark your patients with metabolic syndrome, with the right treatment and the right lifestyle changes. On that note, thank you so much for your kind attention.